Good afternoon or good morning, depending on where you are in the country. This is Mark McClellan. I'd like to welcome you to today's Accountable Care Learning Collaborative webinar, where we're going to be focusing on where MACRA is going and how it might be improved. And we're also going to touch on a range of policy issues and active debates that are connected to MACRA right now. Before we start the webinar, I did want to give you all a little bit of housekeeping information. Our usual webinar setup includes encouraging you to log in to the Zoom webinar on your computer or phone. That way you get the full functionality, although you can join this just online or on the phone as well. We are going to have opportunities for questions. We generally concentrate these in the last part of the webinar, but today really want to encourage you to ask questions or make comments along the way. We may have a chance to address those as we're dealing with each of these specific topics we're covering related to MACRA. So please do let us know if you've got any comments or questions. You can do that using the question module in the Zoom application. Just click on that question box. For today, we're going to begin with a few updates about the ACLC. We've got an important meeting coming up in just over a month. Then I'll introduce our speakers, Clay Alspach and Robert Horne, who will be leading the webinar today, and we'll have some time for questions and, like I said, discussion along the way too. Before we turn to the main content, I did want to remind you about a couple of upcoming activities. Our next webinar is a policy webinar that Governor Mike Leavitt and I will be doing together on April 17th. That's coming up in a few months. We'll have some details for you ahead of then. We expect to have a lot to talk about, not only further developments related to MACRA, but we're expecting some further regulatory developments on the Medicare ACO programs, Medicare Shared Savings, and the Next Gen ACO program. The new Secretary, Alex Azar, will be well more down the road by that point, so some updates on the HHS front, and I'm sure a lot of other topics. So we hope you'll join us at the webinar in April. But coming up even sooner, the ACLC member meeting is taking place on March 6th in Las Vegas in conjunction with the 2018 HIMSS annual conference. We know a lot of you attend that, and with your ACLC membership, you can get special arrangements with HIMSS participation. We hope to see you there. We will be sending around more information about the content of the meeting. We've got some very interesting speakers lined up as we move into the next phases of implementing and supporting our ACLC competency work, the Atlas, and more details on how to apply some of the skills and capabilities that we've worked together to make available for all of us to help improve the progress on accountable care implementation. So should be a really good meeting, and I hope to see as many of you there as possible. Today, though, very pleased to introduce our speakers on the topic of next steps from MACRA. These are two people who are very experienced with legislation like this relating to healthcare. Clay Alspach is formerly Chief Health Counsel for the House of Representatives Energy and Commerce Committee under Chairman Fred Upton. He was extensively involved in major legislation, including MACRA and FDA and many other topics while at the Energy and Commerce Committee, and now is principal at Leavitt Partners, overseeing a range of issues related to these types of policy reforms. And also very pleased to have Robert Horne. Robert spent almost 10 years working on the House Energy and Commerce Committee as well. and also was Senior Health Policy Advisor to Phil Gingrey, who founded the GOP Doctors Caucus. And Robert has concentrated on legislation related to Medicare, as well as some of the other topics that are in the very broad energy and commerce purview, FDA, NIH, 21st Century Cures, and the like. So two people who know this topic and also know the likely further regulatory and legislative landscape related to MACRA. Clay, Robert, I'd like to turn this over to you now, and looking forward to a good discussion of these very important policy topics.
Well, Mark, thanks so much for the kind introduction. We greatly appreciate it. It's great to be with everybody today. And so what we'd like to do today is talk about MACRA and just trying to move forward just 1 minute. And our hope is to have this as a conversation. So Mark, we'd encourage you and want you as part of that conversation too. So as folks are, as we're moving through, please everybody, have ask your questions, provide your commentary. That would be greatly appreciated on our end as we move through this topic. So just quickly, and I'm having an issue moving the slides. Sorry about this, guys. I got it. We're back on. So just quickly, here's the agenda for what we're going to discuss. Today, here's where MACRA is going and how it may be improved. So we're not going to spend a great deal of time talking through the final rule. I think you all are appreciative and understand that. We will provide a baseline just so we can move through. Today's content, as Mark described, will be about more of the recent developments that we've seen and heard on MACRA, and what it'll mean for MACRA going forward, given how important it is for value and important for the healthcare system moving forward. So first, we're going to start on the final rule. So in the 2018 final rule, basically, and the issues of note that have come forward, 2017 was the first performance year, and so I think CMS and providers around the country were able to learn a lot about what worked and what didn't work. And anytime that you're introducing a new law and and implementing a new law, there are going to be some growing pains. And I think with MACRA, that definitely was the case. And so what CMS tried to do in the 2018 final rule for the performance period is provide improvements, as well as try to move the law forward so that it can be stood up, and some of the first year issues, whether it was the Pick Your Pace program that was instituted to help bring providers online, help move the Pick Your Pace forward, help move other issues forward as well. Of note, just a flag, and these will be issues that we'll discuss throughout the webinar. One was virtual groups. The final rule formalized their availability. I think virtual groups, as we'll discuss later in the webinar, is one where continued policy development will be necessary on the part of CMS. And I think they are glad to engage in that and want to engage in it, because they view that as a way that providers can succeed, and importantly, it'll really benefit beneficiaries as well as the Medicare program to get virtual groups not only up and running, but flourishing and being productive. In addition, there was a low volume threshold. One of the, I would say, political, the political issue of note that you hear a lot from Congress, and as you talk to providers around the country, is around clinicians, providers that just don't see a lot of Medicare patients and are small. So one thing that happened for year two is that CMS actually increased the minimum Medicare participation. And so what that means is the threshold was increased. So there are arguably more folks who are not going to be subject or under MIPS. And so that was a development as well. In addition, I mentioned Pick Your Pace. Pick Your Pace was done after a lot of notice and comment and discussions that CMS had around the country to really provide a smooth onboarding for clinicians as they got under MACRA and started participating in MACRA. What you're seeing for 2018 is that Pick Your Pace will be replaced by a transitional provision, and basically clinicians are going to have to report more data It's still not your full MACRA implementation, but it's just like another interim step to get folks closer to where they need to be as they're operating. And then just one final thing is the advanced APMs, which we'll talk about extensively. As you all know, there's the MIPS pathway and advanced APM pathway. Advanced APMs, they were virtually unchanged, but there are some new ones that are coming on board that are important for folks. I think one of the issues that we'll talk about in this webinar is how can CMS and increase the amount of opportunities for clinicians to participate in advanced APMs. I think that is something that CMS is interested, Congress is interested in, and clinicians are interested in as well. And so that is an important topic. And as we're talking about MIPS and advanced APM, they are the two parts. And I think the goal of MACRA, and Robert can speak to this as well as Mark, but the goal of MACRA is frankly to move as many people as possible to the advanced APM pathway. But to do that, it's going to require more opportunities and just more work and time. And that'll be something that we'll talk about in this webinar as well. So moving on, as I just referenced, there are some issues that have been raised, whether it's by different stakeholders in MACRA. I think you all are familiar with it, but this is an important predicate to lay as we talk about opportunities for improvement and what CMS and Congress are interested in. So what I'll do is I'll turn it over to Robert to let him walk through that.
So good morning, good afternoon all. As Clay and Mark expounded on a little bit earlier, we really are here to talk about both the state of the program, but also areas of concern and areas of opportunity. And so first off, and really focusing on the concerns, and these were 4 concerns that have been echoed by Congress, by stakeholders, and by organizations, including CMS and MedPAC. So these are all to be thought of as universal concerns. Number one really is that the law itself is too burdensome. And as you hear the burdensome argument, a lot of individuals focus on the pathway itself from a burden standpoint. I think there are some burden issues on the APM pathway side, but that burden really more relates to the lack of opportunities to get into APMs as a general rule. On the MIPS side, what Congress intended was that reporting under the Medicare program, and this is an important point we'll come back to later, reporting really needed to be a little bit more streamlined and more in line with the provider practice with the goal of reducing the burden. Some feel that upon implementation that a number of the reporting programs and requirements are carried through in ways that Congress did not anticipate. Some of that has led to concerns of burden. It's not to suggest that the burden is the fault of CMS. Congress wrote a very complicated bill, in part due to concerns from CBO and spending concerns that leadership had laid out. But on area number one, it is a topic that MedPAC recently has raised to justify changes to the law. It is an argument that CMS has echoed in public, and it's an argument for which we have seen some receptivity within the Congress. It does not necessarily mean that Congress is sympathetic to some of the solutions that they've seen, but certainly the burden issue is a well understood and common issue across all. We already touched on really the complexity standpoint, and as you think about the MACRA statute, there are a lot of levels of complexity and requirement. A number of them are really specified in statute. As background, a lot of that was not because Congress wanted to get too specific. It's because from a scoring perspective, CBO's pronouncements on the overall cost of the bill, areas where specificity actually helped alleviate some scoring concerns of CBOs. And that's generally why the law has taken the specific and burdensome approach that it has today. As we'll get into a little bit later on, there may be some areas where easing that burden can also help to advance the law at the same time. The applicability and validity of specific MIPS measures is really an area where I think there are a number of different problems, but just use an example for a second. We'll use the resource use calculations that are going on right now. Measure development is, as was contemplated by Congress, is not where it needs to be today. Congress envisioned a place, and use again resource measures as the example, where the cost of a service could be balanced against the clinical outcome that service or product helped to derive. We're not to a point right now where we're able to look at clinical outcome and benefits of those things in a meaningful and systemic way when compared against cost. That is an area specifically that Congress is very sensitive to, that individuals within the administration acknowledge is a problem right now. It's our expectation that some changes to those measures alone are being contemplated and may go forward this year, but it is also representative of a much larger issue, and that is that reporting and measurement at this point in some areas of the program is not as meaningful as some would like. And then really the paucity of advanced APMs, as we think about it, there are areas where APM development from a individual physician standpoint is available. Medical homes are certainly a good example of that. But as you get into certain areas of medicine and certain areas of specialty, and this is not to preclude, by the way, the need for more advanced APMs on the primary care side, but APM development is definitely lagging. And it's an area from a congressional standpoint, when the law was written, was not taken into account the way it should have. It's our expectation as we get into this conversation, we'll identify ways to increase the numbers and availability of APMs and other constructs designed to help inform and advance the development of new APMs. I will stop there, then turn back to Clay and look forward to the rest of the conversation.
So one of the recent developments that we've heard a lot of discussion on is around MedPAC. So MedPAC has come forward with a proposal that was recently voted on by the commission and approved that would repeal and replace MIPS. And that was anytime MedPAC comes forward, given as you all know, it's an advisory agency of Congress that comes up with ideas on the Medicare program for Congress. A lot of these ideas may pertain to different parts of the Medicare program. In particular, this one applied to MACRA. Some of these proposals or policies, as you're familiar with, where Congress gets really interested is around offsets and how to save money. And so whether it was the SGR, how to pay for the SGR, or now how to pay for Medicare extenders, which are before and expired and are currently pending before Congress. Congress really takes the proposals of MedPAC very seriously, and they need to be paid attention to. And so when MedPAC came forward with this idea on replacing MIPS, it created a lot of questions in the mind of stakeholders and a lot of folks following this as to what is Congress going to do with this suggestion? Is Congress going to move forward and try to actually do this? So just to start off with, what is this policy and why did it come forward? Well, one quote is from a staffer of MedPAC for why it came forward is they believe that MIPS is inequitable, burdensome, and will not improve care for beneficiaries. That's a pretty strong statement to come forward from MedPAC, but that's where this is grounded and why they're actually moving forward with it. Robert walked through those stakeholder concerns on the previous slide. That is shared by MedPAC, so that's where it's coming forward. And so the question is what idea or what policy could they put forward that actually would replace it? So I'll go through it really quickly, but basically they provide a series of options that clinicians could, like routes that clinicians could follow in order to get reimbursed. The first is clinicians can make no election and they would just take a 2% cut or some kind of cut and just have off their fee-for-service rate. A second option would be to go through the advanced APMs. A third option would be to do a virtual group. That was another, we talked about virtual groups, we're going to continue to talk about them, but that was something that Med put forward as a potential opportunity. And then another opportunity was basically measured as part of their local or market area. And so this is what they came forward with. Now, some of these ideas that are being put forward, they may have merit, and it's clear that MedPAC has done substantial amount of work and policy work around it. But what has happened is Congress has viewed this proposal, at least at this stage, as dead on arrival. When you talk to the committees of authorization, when you talk to Energy and Commerce Committee, Ways and Means Committee, Finance Committee, they are not going to move forward with this proposal. They have and want to improve the current MIPS and APM pathways and try to find out ways to do that. They don't want to move forward with this. But I do think that this MedPAC proposal, because it's MedPAC, because of the authority that they have, these ideas are important to watch, and this is something that we're going to be watching, because as folks and CMS and others identify burden and identify that improvements are necessary, there could be components of this, I think, of this policy that could come forward if it's viewed by Congress in a way that improves MACRA and improves its probability of success. And one other point that I'm going to turn to Robert to opine as well, but Congress is very much on a bipartisan basis. They want this law to work. They want it to succeed. And so any attempts by folks that are viewed as trying to undermine it are taken very, they're not appreciated by Congress. They only are in a constructive improvement mode. They're not in a mode where they want to, they want to see MACRA succeed. They do not want to see it fail. Go ahead, Robert.
And just 2 points to add to really pick up and underscore a point that Clay made. While the solution that MedPAC has thrown out, maybe to Clay's words, dead on arrival, the reasons for it, the justifications for it are widely accepted, even if they're not necessarily acknowledged in public by the administration and folks in the Congress. And so it's just as a reflection point, MedPAC was calling for SR to be repealed for a while. Congress didn't agree with how MedPAC recommended it, but MedPAC's calling for it certainly was well understood and provided an impetus for it going forward. So it certainly has, that MedPAC recommendation has certainly created some momentum to improve the law in some meaningful ways, and which we hope to get into here in a little bit.
And Robert, this is Mark. Can I just add at this point, one of those pressures for improving how the law is applied is coming in through revisions in the measures that providers are required to report. So CMS has launched a meaningful measures initiative, part of their effort to try to reduce paperwork burden on physicians generally, which is a high priority for CMMI, and very much aligns with what you all just heard from Robert and Clay about intent to try to make this law work. CMS has already simplified some of the measure reporting, and they expect to do more in rulemaking over the coming year to address some of the concerns that physicians have about measures that they don't think matter that much, measures that like on value that they don't think are very much reflective of value yet. So more to come on that. And of course, keep in mind that for all of you who are participating in Medicare ACOs, the pathway is still reporting on those alternative ACO measures, the 30 or so that are part of the ACO APM set, whether or not you're in an advanced ACO like Track 2, Track 3, Next Gen, or Track 1 ACO, you're still exempted from, and are going to continue to be exempted from the MIPS reporting requirement in that APM. Sorry, back over to you guys.
Great point, Mark.
No, that's a great point. And Mark, we'll invite you to discuss this as well. We had a big development this week on the healthcare with Secretary Azar being sworn in as HHS Secretary. And when Secretary Price took the helm, it's inviting questions on where is Secretary Azar going to be on value. That's one of the top questions that we're getting. Mark, I may turn it over to you, and then Robert and I will offer our thoughts too, but I know you've spent a lot of time thinking about this, so we'll love your thoughts on it.
And Alex Azar is very well prepared for this job with a tremendous, really unprecedented amount of experience for a secretary in HHS already, counsel and deputy secretary. He's started to bring on a leadership team around him, including chief of staff, deputy chief of staff, who also have a huge amount of HHS experience. So this is a group that knows how to work in the Department of Health and Human Services, knows how to get things done. Alex Azar has particularly highlighted 4 main themes for his tenure. One of them is dealing with the opioid crisis, but he's also particularly highlighted high prescription drug costs and bringing those down, working on reducing healthcare costs overall, and as an explicit top priority, payment reform to focus on value. And if you listen to some of the details of his ideas around drug pricing and healthcare affordability, those two circle back to the importance of payment reform. We've got one quote from him on this slide illustrating this strong commitment to move forward on meaningful reforms away from volume and building on some of the payment reform steps that have been taken so far, but also to a willingness to really push on new ones. So we'll come back to this as Alex's tenure continues. We've got that April webinar, and we'll of course keep you all apprised by email of other new initiatives. But I expect kind of a reinvigoration of the efforts around alternative payment models, not just for, as we talked about earlier, primary care and maybe a refined, revised ACO program, but also more options for specialized care, APMs, building on the recently announced advanced, and also initiatives that could reinforce ideas like virtual groups and sets of providers taking on more accountability and getting more flexibility in how they deliver care. I really expect Secretary Azar to move forward on payment reform in a more aggressive way compared to the administration to date.
Well, thanks, Mark. We have nothing to add. That was very helpful context for us. On the next slide, and Mark, we're going to ask you to pitch in here as well on CMS, CMMI, and what the latest is. Mark, do you want to opine on this one too?
Yeah, so I touched on this a little bit already with Secretary Azar highlighting that payment reform and therefore actions through CMMI are going to be a priority. As you all know, CMMI has been without kind of a permanent director since Patrick Conway departed early this fall. There have been a number of press stories about that position getting filled soon, probably in the next month or two. Adam Bowler, who's currently the CEO of Landmark Healthcare, so a healthcare company that focuses on very high-risk, complex patients, and does so through kind of an alternative payment model, subcapitation contracts with Medicare Advantage plans. Has been doing very well in improving outcomes, reducing costs by all reports for that population. He's been suggested as a potential CMMI director, and I think would come into the job obviously with a lot of firsthand experience in how to actually implement care reforms in for a very complex population, the importance of alternative payment models and working with CMS and Medicare and doing that. So the kind of person that you'd like to see in a job like this to work as part of a team with Alex Azar and Seema Verma accelerating payment reform efforts. CMS recently announced, as I mentioned, the successor program for hospital-based, largely episodes of care, though they've expanded it to include some physician specialized episodes that might be managed either by physicians in hospital or for some patients on potentially an outpatient basis. And as I said, more coming on specialized care and drugs, among other areas. One other issue that I'd like to highlight in terms of new directions for CMMI is a strong commitment on the part of Seema Verma and Alex have highlighted this as well, to try to get beneficiaries more engaged in payment reform. So we saw a lot of reforms in the previous administration through CMMI focusing on provider payments and sharing savings and sharing risk with providers. I expect to see more steps building on things like the value-based insurance design pilot in Medicare Advantage, a small one that started last year involving diabetes and some other chronic diseases. I expect to see more programs like that that emphasize giving beneficiaries information on their care options, maybe choosing not just individual providers, but maybe choosing providers that are in ACOs or alternative payment models, and being able to get some of the savings, or at least an opportunity for savings, when they do so. So think of it as maybe more shared savings on the consumer side. This may be a bit of a challenge for implementing. I know many providers are feeling like the payment rules are already pretty tight, but I'd look for CMS to want to work pretty closely with providers to make these approaches work. As you heard earlier, they really want to engage beneficiaries as well as providers in making the alternative payment models more attractive and effective. Along with all of this, another big theme is trying to reduce administrative burden. So maybe with some revisions in the APM programs coming soon. CMS had RFIs out recently, requests for information on both the measurement requirements in MIPS and more generally in APM, and also some of the other regulatory burdens associated with the program and with alternative payment models in particular. All of that will go into the policies that the administration will be implementing through CMMI in the coming months. So not a huge amount of actual policy implementation yet, but certainly an expectation for all the reasons we've been talking about today, that a number of new initiatives and regulatory reforms are coming.
Thanks, Mark. Our development is to this and spend a little bit of time when we talked about MedPAC and their proposal about where Congress is. We just want to kind of amplify on specific steps Congress is taking that really do show that commitment. First is just since MACRA's enactment, usually what happens with Congress is once a law is passed, Congress moves on to some other problem or some other issue, and it doesn't come back for years. And with MACRA, that was one of the questions was there was a huge bipartisan interest in MACRA. Would the committees of authorization, would they move on to other priorities, or would they continue their focus on MACRA? And the answer to that question is they're continuing their focus on MACRA. If you look at Senate Finance, Ways and Means, and Energy and Commerce committees, they all have held hearings on MACRA since its enactment, which is a huge development and shows that Congress is interested and wants information, wants to play a role of oversight to ensure it works. The most recent hearing that was held was an Energy and Commerce hearing in November. And important with that hearing, especially with this audience, is that it focused on APMs, and the whole focus was on APMs. I think that in talking with folks and policymakers, and you know, in this call, like I may be guilty of this, we're talking about MIPS the entire time, when APMs is really where the policymakers wanted, that's where they want Medicare to go, that's where they want the system to go. And what the committee wanted to do was help educate its members in Congress and the public about the opportunities and what stakeholders are doing around APMs. So that was the hearing in November, and it really was meant, it was specifically picked out and talking to the members and staff who worked on it to show the commitment of Congress in moving forward with MACRA and including their priority around APMs. And so that was the latest. I think the question is, what comes next? Can you expect next from Congress around MACRA? And the answer to that is that it could come actually very soon, but there hasn't been a lot of public discussion on it. So right now, and I alluded to this earlier too, the Medicare extenders have expired. So these are a set of extenders that used to ride with SGR every time there was a patch. These are programs that are Medicare programs that are important to beneficiaries, but they don't have a permanent solution. And so Congress will come in every couple years and provide more money so they can continue. So one of those is a therapy caps exceptions process. That's a really popular one. There are some ambulance programs that fit this. The special needs plans are another one that fits this. So there are a series of these. And I'm going to turn it to Robert in a second, but there's been discussions among bipartisan staff. This discussion started over the summer, or frankly last spring, around how to reauthorize these programs. As part of these discussions, they're also talking about other Medicare issues, including MACRA. And Robert, maybe you could share a little bit about what ideas could come forward as part of those discussions, maybe even some tweaks to MACRA.
No, quite great question. And as a baseline setting issue, I think it's important to note that a bipartisan issue within the Congress, within the healthcare landscape, that does set it apart a little bit from some other areas that you've seen break out into the press and have been talked about writ large for the last year or two, but really even beyond that. And so it really comes from a couple of different factors. A number of the staff that worked on that bill are still on the committees of jurisdiction and frankly still have a ownership issue in that law and want to see it work. Number two is a number of the members of Congress that backed it, including the bill sponsor, Dr. Burgess, remain on those committees of jurisdiction, and they as well want to see it. The third issue, frankly, is nobody wants to go back to an SGR scenario where every 3, 6, 9 months Congress needs to act to patch something. It's both I think it's representative of the time that it takes, but also bipartisan agreements on healthcare policy are really becoming harder and harder. And so in looking forward, one or two areas that we expect to happen, one we already mentioned, and that is resource use under the Medicare program. I think it's widely accepted that absent an ability to look at both cost and the quality of the outcome and compare those two issues together within a measure, that measuring just for cost at this point may create access problems and quality of care problems for patients. And understanding the signals that the Medicare physician payment system can send it to providers and the fear that has resulted from the beneficiary community. It's expected that they're going to address that. It's not to suggest that a review or measuring of cost will go away, but we do expect some intermediate issues to come up to help deal with the absence of a good quality outcome comparison for right now. The second area, frankly, is beyond the extenders. We are picking up an interest from policymakers in smoothing out some of the areas of concern with both the APM pathways and the MIPS pathways. The MIPS pathways, frankly, are there ways that we can decrease burden but increase the meaningfulness of the reporting? That seems to be a common area of agreement. Number two, from the APM pathway, how can we create more opportunities for physicians and groups of physicians to engage in APM-like behaviors if they want to? Those are two areas that really do serve as a good foundation for positive reforms that advance the law, but also address some real issues that.
Well, thanks, Robert. And then just one final recent development, and we're running out of time, so move through this pretty quickly. But as part of MACRA, there was a physician-focused payment model technical advisory committee that was established. And this committee is established to look at different payment models and provide a way that it's not only through CMMI, it's also through this avenue that models can come forward and serve as advanced APMs. I think where we are on this committee right now is that it's still, folks are still trying to find and still trying to understand what can move forward through this committee and how it can be embraced by CMS and HHS. To date, that has a model has not been approved, and I think that is something that folks really want to work on and improve. And as part of that committee, Energy and Commerce Committee hearing that we flagged, that was part of that conversation. They actually had members of MEDPAC, and they had, they want to see what they can do to make this avenue a worthwhile avenue for the different stakeholders that want to get their models established, because there just aren't enough opportunities right now, and there's interest in creating more opportunities.
And Clay, in the interest of questions, I can probably go through some of the areas of solution in about 90 seconds.
Well, then, okay. So where we go from here, I think what we're going to do is walk through these specific issues and provide just our thoughts, and Mark will as well, on where we see these specific, on these issues where we see the law going. So as we already discussed, and we won't belabor it, but there is commitment now from Congress and the administration on value. That is really clear with Secretary Azar. I think more frankly, there's a greater clarity from him than we had before. Congress is committed on a bipartisan basis on it as well, and that extends to MACRA. That is the one of the major legislative initiatives that has been put forward since the ACA, and I think that bipartisan belief still stands. And they do want to make improvements and are looking for ways, even outside of MACRA, that they can move forward value and move forward with those policies. APMs. Mark, do you want to handle and talk through some of the more opportunities on APMs that we see coming forward?
Yeah, we've already touched on a number of these. So I talked about consumer approaches. We talked about prescription drug related initiatives. This would highlight a couple of other points. One is the desire of CMS to work with the private sector, commercial insurance plans, including Medicare Advantage and Medicaid managed care plans, on more aligned payment reform. So CMS has also already taken some steps to clarify how alternative payment models in those programs can help count towards advanced alternative payment model qualification over time to get the 5% AAPM bonus. There's a higher threshold for a larger share of organizations or provider reporting groups payments coming through so-called qualifying advanced alternative payment models, and CMS will be doing more to clarify that in the coming months, so that there are again more of an encouragement to the private plans to lead in multi-payer payment reform initiatives that CMMI has undertaken, including for primary care and cancer care. Some of the specialty models that are likely coming will fit into that category too. Wanted to highlight direct primary care as well. This is, as you all know, an approach to primary care that essentially gets out of the fee-for-service billing. I think the challenge that CMS is running into is where to draw the lines from a standpoint of a fee-for-service program between what counts as primary care and what a direct primary care provider would be expected to include in their services, and what might be excluded. Also, could this kind of program be implemented in a way that reinforces some of the other payment reforms? For example, maybe a combination of a direct primary care model and a shared savings ACO might be a forthcoming option for physician groups that are interested potentially in participating in the ACO program, but maybe want more flexibility in how they bill for primary care services. So probably an initiative coming there too. And CMS has really emphasized how it wants to see state leadership in solving overall problems of affordability and access to care, and making it easier for Medicare payment reforms to align with state reform could be part of that too. It really is a long agenda on APM expansion, and directional ideas start turning into actual programs.
Thank you, Mark. The next one is virtual groups, and Robert, why don't you share where we see this going?
We'll go through the next four pretty quickly, but we'll open it up for questions and then certainly can follow up afterward as well. On the virtual groups, really what we're getting to explore with policymakers a little bit is what a practice virtual group would look like. As you all know, virtual groups right now are a reporting mechanism under MIPS, but there may be ways that practice virtual groups can begin to allow different providers from different areas of medicine to practice around chronic conditions or disease states. Certainly an area that is receiving a lot of interest right now, and an area that could help inform APM development in the future. Number two, from a technology side, we really see a lot of potential that technology can help inform both model development within the program, but also empower providers to better partner with CMS. Role. And so the role that EHRs and registries can play, both to take burden off of the program, and you think about real-time feedback, but then also the way that those platforms can help gather data and identify new delivery changes in the program could certainly be very significant for APM development. Number three, from what we're calling eliminating barriers, we really are starting to play with, and we do not see much difference between an APM philosophy and a value-based contracting philosophy, in that these various arrangements are generally designed to create alternative contracting and practice methods under what is currently allowed for under the program. We see ways in which providers, manufacturers, payers, and patients could all work together in the same arrangement, satisfy the different requirements under the program. As an example, a provider participating with a manufacturer and a payer in a value-based contracting arrangement might get some recognition under the MACRA statute for participating in a quote-unquote APM. So again, it really is looking for ways to drive that value proposition forward. And the last is, and as we talked about, today MIPS pathway and the APM pathway could almost be considered as separate pathways. We do see opportunities for MIPS reporting, to harken back to an earlier message, to be more meaningful than it is today. And one of the ways that we envision that would really be to allow MIPS reporting to focus on delivery model changes for the purpose of gathering data and helping CMS identify what delivery changes in healthcare could serve as the foundation for a payment change, which basically, in its essence, is an APM. So these are four areas that we do see some opportunity for in the coming year and beyond. There are a couple of areas that do help advance the law, both in terms of its meaningfulness, but also its pathway to drive value, and things that we do see policymakers beginning to gather around a little bit.
Great.
And that's it, Mark. Any questions or yes?
Thank you all. Yeah, we do have a few minutes for questions, so please use the Q&A tab, and I'll get to a couple of those in just a second. But I just wanted to add a final comment. As you heard, there are some common themes emerging here in terms of where CMS and HHS are likely to go on MACRA and all of these related payment reforms. But it is a really opportune time with the new leadership coming in. So next few months will be critical to see just how all of these pretty clear policy directions and goals from the new HHS leadership team and the initiatives at CMS and the probable new leadership at CMMI, how those directions really translate into specific initiatives. But I think the directional goals, as you've heard, are pretty clear. Not legislation, at least fundamental legislation on MACRA, and really working hard to see if through regulatory and administrative steps, these payment reforms can work better. To the last discussion around issues like anti-kickback rules and other potential regulatory barriers, keep in mind that the new secretary is a really sharp legal expert who has incredible experience in understanding HHS-related law as previous general counsel. And so does his chief of staff, who's also a legal expert on healthcare issues. So I expect to see some more action there too. And again, we'll keep you posted on how those developments happen. I did want to turn to a first question that came in, touching on some of the issues that we brought up around additional possible directions for alternative payment models. Question basically points out that there are some well understood alternative payment models that are still working through how to make them better for primary care and kind of population focused care through ACOs, but less out there for hospital-based services, physicians who provide quote unquote non-patient-facing services. I'm assuming that means radiology, pathology, and the like, where there don't seem to be as many options for participation or, as I said, even getting on the field, as the question said. That also asked where the efforts in this area are going, and we talked about some of these directions already. The questioner pointed out that a lot of the workload has fallen on the specialty societies. I think that's right. Most or many of the specialty societies are working on different kinds of alternative payment models with a lot of submissions to PTAC, and we touched on PTAC before as well. Clay, Robert, I appreciate any comments that you all have on the further on the legislative outlook or other steps to help address the APM gap for especially providers. We'll just say that even in MIPS, there's been I think a relatively high rate of frustration among some of the specialties who feel like the measures available just don't fit their practices very well. And at least some of them, the ones that aren't small enough to not need to participate, are choosing, at least so far, not to participate and just take potentially a payment reduction. So we do think that there will be more efforts around bringing alternative payment models forward in this area. I personally think that some of the models that have gone to the PTAC so far, which is really created to help with this problem, haven't really fit well into both overall CMS strategy and some of their operational considerations. So CMS is really looking, even though it's called the physician-focused Payment Reform Technical Advisory Committee, most of the CMS reforms being implemented are ones that are kind of patient-focused and that involve encouraging more providers to work together better. So payment reforms that just focus within a narrow specific specialty, even if they do something like bundle payments or encourage equalization of, say, reimbursement for colonoscopies between a hospital outpatient and an ambulatory practice setting. It's not that CMS thinks those issues are important. They might end up dealing with them through further modifications in the fee-for-service schedule. So maybe introducing a little bit more bundled payments there, or as CMS already announced this past year, equalizing payments for hospital outpatient services and ambulatory specially provided services in some areas, as opposed to making them part of an alternative payment model, especially an advanced one where, again, CMS is really pushing towards more fundamental changes in getting providers to work together differently, new ways, with a patient focus. So more on this is probably coming, as we've described. But Robert, Clay, any further thoughts about what's ahead for specialists and alternative payment models?
And Mark, maybe just to build off of the great points that you just made, but 3 additional areas, some of which we've already touched on. A, if there was a MIPS reporting option for providers where the consequence was not payment per se, but it really was for data gathering, that might really speed up model development in areas that are certainly lagging, specialty being one of them. Number 2, on the virtual group side, the benefit of a practice virtual group really is to take a page from what the ACOs have done so well, and that is allow areas of specialty and even subspecialty to combine with other providers and be measured under and scored under an APM as a group. If you think about, let's say, just an area of diabetes and the different types of providers that episode can touch, allowing APM development around such episodes can really drive forward opportunities for providers, but could also really improve the quality of patient care that patient is receiving. And third, and again, there are probably more ideas than this, but the potential that thresholds for APM adoption are not a one-size-fits-all. Congress, when they created those thresholds, frankly, had a medical home model in mind. The thresholds are very ambitious and do preclude a lot of specialties and subspecialties from getting out. Also, rural providers. The potential that different sets of thresholds for different areas of medicine could better align adoption for areas where an APM is available are certainly another way to help address this issue. And our expectation is as time goes on, there will be additional opportunities to address this issue because this is a commonly held, there's a commonly held understanding that this is a problem that needs to be addressed.
Yeah, great. Very, very interesting. So challenging area, but one where I think, as you said, this idea of kind of aligning payments on the specialty side with some of the efforts on the primary care, more generalist side to get improvements and say outcomes for complex patients or those with conditions like degenerative joint disease or cancer or liver disease and the like. I think that's where CMS would really like to go. And again, I'm sure we'll be seeing more on this in the coming weeks. We are about out of time. Just one last, maybe quick, if not easy one. Clay, Robert, it sounds like you don't expect to see much major in the way of MACRA-related legislation. Any bets on healthcare legislation that could actually move forward in this election year?
I think it's probably down to like 3. I think opioid-related legislation is going to move forward. Congress is still looking for ideas. There are some ideas they put forward, but that's 1. 2, you have the FDA user fees, the animal drug-related user fees that could move forward. 3, you also have the Pandemic and All Hazards Preparedness Reauthorization Act. And then 4, which is a legacy item, but you have the Medicare extenders, community health center, public health-related extenders. That's going to move forward likely in the next month or so. So there is stuff that'll move forward. It's not going to be entitlement reform, but it will be. There will be healthcare legislation this year. Anything else, Robert?
No, I just think I think the desire exists to push healthcare reform issues, and that's generally not related to any one law. I think the issue becomes where can they find common agreement, but at least the political impetus is there. Continue to try to identify areas for reform to happen, Mark. So it
For bipartisan reform.
For bipartisan reform.
Yeah,
so it's going to be a very active year in healthcare still. Okay.
Great. Well, Robert, Clay, thank you all again for joining us. All of you who participated in this webinar, we appreciate your being with us too. Remember about the upcoming ACLC in-person meeting on March 6th, and we hope you have a good rest of the day. Thank you.
Thanks all.
Thank you.